5 kilogram weight loss, which is significant. Abdominal pain and recent onset constipation. Again, recent change in bowel habit हुआ, ठीक है? She has a history of stage 4 chronic kidney disease. ये CKD1, CKD2, 3 ना, almost everyone in UK has got CKD3 ना, वो अक्सर मैं हंसता हूँ ना, जो मैं इतना मुझे नहीं पता. लेकिन stage 4 is EGFR less than 60 ke 40 mils per hour ना, ठीक है? And she's referred for colonoscopy. How would you proceed?
Phosphatemia should not be used in this case.
हाँ जी.
And colonoscopy is indicated in, she can be carried on with colonoscopy.
My colonoscopy is indicated. My investigation of her bowel is indicated definitely because she's got a significant weight loss. She's got a change in bowel habits. ठीक है ना? तो वो तो that is definite. Main जो उनका issue है तो that is stage 4 kidney disease because of hyperphosphatemia ना. So you are concerned. So you would not use a phosphate enema and you would not use a phosphate based laxative जैसे आप पिकोलैक्स वगैरह यूज़ करते हैं. हम लोग यूज़ करते हैं वो मूवी कॉल या जो वो होता है ना ये क्या क्लीन प्रेप या मूवी प्रेप, ठीक है? So that is one thing. So basically that's the message ना, क्योंकि it would cause hyperphosphatemia. दूसरा, you have to be careful that they are not fluid overloaded with those, ठीक? Next one is 67-year-old man with long-standing ulcerative colitis is on the surveillance program, having colonoscopy every 2 years. 5 months ago, he underwent coronary artery stenting and is now taking clopidogrel. He is due for colonoscopy. How would you proceed? Coronary stent he's got, and he's on clopidogrel, right? And he needs a colonoscopy for. Pardon? Huh? Can't. He can. अच्छा ठीक है. लेकिन would you take any precaution? Anything? Yes, no. अच्छा. अच्छा.
If you want to go on therapy, then we have to stop the clopidogrel for at least 1 week or 3 to 4 days.
We are not taking biopsy and
हाँ.
biopsy even on the patient who often can be taken. Biopsies can be in the patient who have gone for the stenting. We don't have to stop the body. That will cause stent sepsis.
ठीक? Fine. That's good.
I'll just tell you, in the UK, when clopidogrel first come out, no one knew anything about it, and I always remember when it was first introduced, the unofficial advice was, do what you would normally do in a normal colon and we'll see what happens.
Yeah.
We're doing the same.
Yeah. Generally, if you are on clopidogrel, it's not a problem on its own. If you are taking a combination of aspirin and clopidogrel, then that's a problem. Then you should stop them, or at least stop one of them, aspirin usually, right?
How scientific is the biopsy-based evidence with the aspirin and clopidogrel?
Only biopsy is not a problem.
That's what I'm saying.
Yes, sir.
That's what I'm saying.
It's
But
anecdotal.
we pay a lot of attention to it, but I don't know how the evidence certainly is not of the high.
No, it's not.
I biopsy with clopidogrel and aspirin.
Biopsy, even you biopsy with warfarin and heparin.
Yeah.
It's if you want to do a sphincterotomy or a polypectomy, I wouldn't do it.
It's the clopidogrel that I get concerned about.
Yes, yeah.
Because there's one study that has shown that if you, with regard to polyps,
Yeah.
72%, those patients studied who were on clopidogrel who had a polypectomy, 72% went on to have a significant bleed.
Yeah.
And that's the evidence for
Yeah.
that study.
But for biopsies, you don't bother.
For biopsies, you don't.
That's what I meant.
Yeah.
Even if the
Yeah.
patient was on aspirin, it plus clopidogrel,
Still
it
biopsy.
would not change anything.
No,
for
you
this
wouldn't.
particular patient.
No, you wouldn't, right?
on occasion we have operated cases of tracheotomy.
Oh, well, you see, if somebody comes in emergency, you don't have time.
You don't have time. Secondly, you always look at risk versus benefit, because stopping the clopidogrel in this patient is going to cause more harm. His stent might block off, right?
Okay. Should
Okay.
we-
Yeah, I
should-
think so. Yeah.
Should we get, oh, you want to go,
Huh.
isn't this something that you did?
I think this is the same thing. Yeah.
You know,
Yeah.
It goes down the
Yeah.
low risk, high risk.
Yes. Yeah. Right. Okay. So.
So we'll go on to the,
Huh.
do you have any, this is the last one?
I probably will just.
Chalo, ye last karke karte, this should be the last one, and then we'll have the jack thing.
82-year-old woman undergoes colonoscopy for iron deficiency anemia. In view of her age and frailty, she was admitted for bowel prep. So she was an inpatient, right? Procedure is prolonged and difficult. Because of severe diverticular disease and very poor bowel cleansing, a 5 millimeter polyp is removed from the transverse colon by hot biopsy. You are called to the recovery area because she is complaining of severe generalized abdominal pain. How do you proceed?
Keep her NQ. We'll get an abdominal X-ray reference of mine.
Okay, good.
And we'll keep her NQ pass and NGQ and keep her on RG.
Okay.
Then RG.
What are you considering here? I mean, what are your differential diagnoses?
Bowel perforation.
Yes, good.
And
A full thickness burn, right? If it's not a, right? And possibly to excess amount of air in the bowel, because it was a difficult procedure. Patient had diverticular disease. That's one. So you might have put in too much air in. But having said that, the possibilities are that a 5 millimeter polyp was removed by hot biopsy force and should ring the alarm bells. Secondly, diverticular disease, if it's a novice colonoscopist, might have gone through that in a difficult procedure. So yes, you would do a erect supine, you would assess them for peritonism. It might not show air under the diaphragm, but as we discussed earlier, it might have caused a full thickness burn.
I think, Maka, what they're trying to get at with the question as well is that there's one thing that on there, they're talking about the use of a particular item, a hot biopsy. Is that an appropriate place, is what they're saying? Now, I know people who are still doing hot biopsy in the right colon and the cecum, and they're saying they're having no problems with it. They've never had any problems. The thing about doing a polypectomy, which is very common, we put enough air in, the word is enough air, to actually see what we're doing safely. A lot of the time people, when you actually, surgeons will tell you better, is that when you put a lot of air into the cecum mucosa is only a couple of millimeters thick, 2, 3 feet. If you actually grab that with a pair of force, you're virtually full thickness, and that's where the problems have come. So, one, it's biopsy technique, and two, it's actually using hot biopsy forceps. So the further around the bowel, transverse colon and onwards, it's nationally frowned upon in the UK to use hot biopsy forceps. We use them in this country, we don't use them because of increased complications.
Fortunately, it's not available here in most centers.
I mean, this is what we discussed in diathermy as well, that it's banned in our unit anyway, right? I think that's probably.
So that's
Right, I think this is simple, straightforward, right? Okay, so we'll stop here and let Paul present his JAG bit, right? Okay.
Right. Now, yesterday you'll have heard Brian go on about national, local, regional trainers and training. What we have in the UK, by the way, that's Brian. That's Brian 10, 15 years ago.
It looks pretty much the same.
Oh, he's fatter than.
Do you have one of yours? Like 15 years ago?
I was thin and handsome.
Yeah.
You should put it up for.
I had a lot of hair then. I'll show you. Right, so what we have, it's online. It's a system where you as trainees log in and you keep your log online. It's for surgical trainees, it's actually interlinked now with the surgical logbook, and so therefore the two talk to each other. Up until about 2-3 years ago, it didn't. It does now. That was all revised, but also certain aspects that we have to cover. Now what we have are regional. My friend here, he's head of training for his area. Okay, he's head of endoscopy, head of training. Then that's for his hospital. Then there'll be a regional training lead, then there'll be a national training lead. The national training lead is Brian, the regional training lead for the Midlands is myself, and then there's one for the South, one for Wales, all these type of places. What we do is that we come to this area here, you can select courses that are available. Okay? So you look at the thing, it tells you what you can do, and you select the training centre that you wish to go to. If you look, you can see what are on offer. These Australia, it says training, but it's they've only just mimicking the system. A lot of these are talking about what they offer in relation to endoscopy. Some of it is biometrics, some of it is looking after people with special needs, etc. If we look at where Brian's from, where St George's, they love themselves.
No.
Oh, don't they love themselves.
Leicester.
Right. Nothing against Roger Lester. God bless him. Right. So when you go to there, they're actually, when I've told you, when they were talking about 16 training centres, they've pulled. That's why I showed you that one. So they're no longer doing it. So even though there's 16 centres, there's 6 regional centres with satellites, but several of these are pulled. Okay? You can select the course you want to do, advanced skills, and then you sign in and it can tell you where to go. It tells you what to do. At the moment, no one's offering that course. We have a username. Right, let me think if I remember what mine is.
It's more like password.
Yeah, that's it, yeah.
What's the password? Paul, is that your name now? The name looked like a password and the password is your name.
Yes, that's the problem with it.
That's the problem. That's the problem. So you come to this. If you're the training lead, you get access to this. This is the nursing part, and also, this is also a part for your administration. And it says what the unit is meant to actually meet. There are various things that they're meant to meet. Various training leads, and we can actually say what the portfolio is. Courses, this is my e-portfolio, but you can talk about what courses are available and send the nurses on them. Jets is what you're interested in. Now with Jets, e-portfolio. Now I come to this. Now with this, I'm able to see all the trainers and the trainees that work with me. And you may be amazed, you may not be amazed. If we go to my trust, if it's highlighted yellow, this person is not the training lead, she's admin, but if I didn't put her as a training lead, she couldn't have access to alter a few things that I needed to do. So she's not learning, she's not doing anything. This person you should know is a consultant. You should know, he's from Islamabad. And then you come down, all of these are trainees. See all the trainees? Now, Saqib, he's a chap who's from Karachi. Now, Saqib won't mind me showing you his portfolio because that's what I'm going to do anyway. I can actually amend his e-portfolio. I amended him to trainer because that's what he's capable of doing. I'll go back to this one, just show you what it is. So as you can see there, I can adjust this. Not everybody can adjust it, only the centre lead or the regional lead. At my unit, to actually move somebody on, I discuss it locally, etc. And we see what their e-portfolio is doing. And you can see where they're up to. If again we come back to Saqib's, where have we gone? Come on, Saqib. There we go. So every procedure that he does, he'll log it. If we look at, I can look at his summary, so that'll tell me where he's up to. Just waiting for it to work. Okay. Tells me what courses he's been on, tells me where he's been. I can check his cecal intubation rate because it's put in. I can check his completion rate because it's put in. And then I can choose individual procedures at the top. We're interested in colonoscopy. His cecal intubation rate with me was this. I've just seen this and I've just seen this, so I'll be phoning him up when I go back and asking him why. And I've seen this go down as well, so I'll be folding him up again. So I do keep an eye and I check it once a month. He's only just left me, so about 4 months ago, and this is what's been happening. I did tell him off about this, but it hasn't come up enough. This tells you what he's doing individually, so you can see number of OGDs, flexi-sigs, colonoscopies.
This is quarterly.
This is quarterly. This is the important bit. We look at, there are various things that we report on at the end of the year. There are various key index parameters that we're looking at. One is fecal intubation rate. 2 is in the over 70s, what have you given? Have you given pethidine? What's your mean dose, etc. Under 70s, how much have you given, etc. Any complications, reasons for the procedures. And when he was with me, completely, all of this stuff, EMRs, he did 36 EMRs, he did 28 completely unassisted. The smallest EMR he did was 3 centimetres in the cecum. And out of the 26 unassisted, he did 22 of those were in the cecum. This here, at the bottom, comfort scores. This is something you need to be looking at in your own departments. The comfort scores are said by the person who's working with you. So not the other endoscopist, not your trainer, it's the nurse or your tech guy. They look at this and they say what the comfort was for that patient. Any adverse events? None. Never perforated. No admissions. That's what that goes on. Okay? So then when we come back to that, that's his profile, that's his numbers, that's DOPS forms. You've seen a few of you will have filled out a few of those. And you fill out your DOPS forms and everyone that gets put on comes onto the system here. DOPIS, we also do ones for taking off polyps. That's when he come to me and that's when he left. And he dipped and I'm going to have a word with him. Okay? And then appraisals. They haven't done an introductory appraisal at his place that he's gone to. I always do. It shows up if they've done an introductory or an exit, and they should do a median one as well, but they haven't. Now, JAG certification. What happens with this is that once you've done, and you're interested in colonoscopy, once you've done so many procedures, you have to have got fecal intubation rate above that, unassisted, formative. So these are the amount that are put on by myself or watch. Every procedure is watched. Can you see the numbers that he had done? See this? Until he was accredited by myself as being able to perform procedures unassisted, which means me not in the room, he had up to 680 procedures on there. And I accredited him before he left me, and he added another 60. So he's only added a few since he's left. But the most important thing is that on my unit, nobody, and the same as Vakar, in our unit, nobody performs endoscopy without a trainer in the room. Nobody is allowed to do the see one, do one routine. So if I ever found out about somebody who'd say done 5 procedures, or somebody say from this course, that doesn't mean you're now accredited to go and perform endoscopy. What this means gives you an insight on what a safer technique on doing colonoscopy. It's about being able to perform it with a little bit more respect, etc., but still need the close support and guidance of your peers. We in the UK, I would absolutely go ballistic if somebody, and you wouldn't like me if you saw me mad, I would go ballistic if I found somebody was doing these procedures unassisted if they'd not been accredited. Okay? 1, it's unsafe. 2, we have a standard. But 3, and most importantly, you need to be looked after. In the UK, there is this thing, accountability and credibility. But also you've got to look after, the biggest badge of honour is every procedure you do, your name goes on that report. Your name is your reputation.
For every procedure you do, that's your reputation being put up to be looked at and be examined. So if you're a chap who's not done many and is often getting themselves into difficulty, you've got to have the support of your senior, who should be there with you to offer you the guidance that's there. It's not fair on you, but I would say to you, think about your reputation, think about what the safest thing is, above all for the patient. And again, going back to what we were talking about this morning, if it was your mother, would you like to actually have someone who's just freshly come on, say, this course, who's maybe only done 50 procedures, doing your mother's or father's procedure? I certainly wouldn't. If we come down, we can see their accreditation. So I'll show you this one, so you can see what it looks like. You can view the dots. And it's on here for life. So you can see what they fit in. I have to observe them doing this. You observe them doing everything. If you're unsure about what something means, the question mark gives you a guidance on what it is. Okay? All procedures, colonoscopy, with sedation or no sedation, we put a cannula in. Okay? We also follow certain guidelines. Endoscopic skills, it tells you what they are. Come down further, you can actually see what they are even better. I say that basically it's 1, 2, 3 and 4. Regardless what you're looking at with the 1, 2, 3 and 4, number 1, you're just starting out. So I'm being nice. Basically they say you're very poor. Number 2, you're just starting to understand the rudiments of what you're doing, and you're starting to understand what you're meant to be doing and how to correct things. 3, you finally started to see the light and you're moving on. And 4, you're comparable to my standard. And if you're 4, then that's fine. It covers all aspects, and also my opinion on what the test was. It then gets all sent, and I electronically sign it, it gets submitted to a central office, and then he has to pay so much money, £70, to get accredited.
Every year.
They're introducing it as every year. Okay? And as the person had done this, if I haven't done it, I can't do that. I can't sign him off. The most important thing about this, and the thing that I'm most proud of, is about you as a trainee. Now, as a trainee, often you feel that you're working with a trainer. Me, myself, if you're coming to work with me, you will work with me for a minimum of 6 months, 1 list a week. I'll say to you, we have a chat, sit down, what your aims and objectives are. And Sakiba's with me, what's your aims and objectives, where are we going? And then we sit down every 4 weeks and see if we're meeting what we said we're going to meet, see what the targets are. That's what a trainer should be doing. No, that's what Lakar does. He sits down, he's told you himself, takes to the office, talks about them, what is it they want, all these type of things. And then he goes on to sort out his documentation. The thing as a trainee is often you need to be able to support the trainer. The interesting thing about this system is that you can anonymously put on this system feedback on the trainer. Okay? That means yellow means good, green means really good. Okay? But that's what gets put onto the system. You don't know who's done it, you don't know who said it, you don't know what they're going on about. You can see that there. These are recent ones. It's nice when sometimes you're feeling you're having a bad time, you can go back and you can look at these things, okay? And you can say all this. So I think, oh, well that's nice, oh that's nice. Okay? So the most important thing is that you I don't know who's written it. And the other thing about it is, if I worked with you today, you were on this system, you don't have a time when you have to put it in. You can put that in in 6 weeks, 3 months' time. And if you had the mindset, that's what I would do. Because if you're going to write something, but I have a talk with you and I say, if you don't feel you can tell me that there's a problem, you know, then the problem, there must be a problem. So if it ends up here that there is a problem, and I'd have preferred it that you would have actually pointed it out. That's all I would say to you. I've not had any problems. I've not had anybody, but the most important thing is trainers, we like to have feedback as well. So you get an opportunity for feedback on the trainer, as well as we officially feedback on yourselves. Yours is protected for your anonymity, because I think that's right, but on us, it's fed back, etc. Now the most important thing also that you get fed back on is your courses as a trainer. So up here, now you're asking me, how do I get accredited? I go off to these courses and these chaps look at you and then they assess you. Brian McKay is exactly the same as me in the sense of, I like my car. Hopefully he likes me, just his friend. I like my car. But me and Laka would work together, and I've got no problem at all. And I would gladly fill this out. But because I like my car, and because I respect the man, it doesn't mean I'm not going to talk to him if I didn't think he met the stand, or he wasn't a 4 in the standards if he was only a 3. I'd sit down and talk to the man. The most important thing as a trainer is to stand up and be able to turn and say, well, you gave me a 3, but why have you given me a 3? Okay, I understand that. I take it on the chin and I'll do something about it. Because I don't want 3s. I want 4s. We're all trying to strive to do something. And it's not because I know the guy, I'll show you one of the others, but we have this. And now it's filled back on us. Okay? What this does, it puts you in a national league table as well. So we know what our secret reservation rates are, we know what our feedback scores are, and we know where we rate. And that's the most important thing. And as a result of that, those people with the highest scores get invited onto the courses as faculty. Those people who are supporting their trainers the most then get asked to actually run the courses and get up to all sorts of invites. As you can see, all that goes, and that means it's easy. Hopefully that's what you thought. The system itself, has taken a long time to get going. It is now compulsory. Initially it was optional. The most important thing is, and probably Waka is probably been a good board, but I haven't. If I was to look at anybody else's training summary, my training summary, because I did all my training pre this system, I don't have any lists, I don't have any training, I don't have nothing. My JAG certification is this. My JAG accreditation for is this. I don't meet the criteria at the moment. That's because it's I'm pre this system. Anybody like Bakar and myself, we're pre this system. Saad's pre this system. He gets automatic accreditation.
I would have failed the flight.
No,